In this series, we'll be discussing on the optic nerve. Now, typically, I've divided this lecture into these parts. So, first, we'll be discussing about the optic disc and papilledema, that's associated pathology. Next, we'll be discussing about the macula, and as you know, macula is the is this central vision, and it's the most important for vision. So we'll be covering the aspects of vision in that. Third lecture would be on the optic nerve and the optic chiasm and the arrangement of fibers, etc. The fourth will be on the optic pathways beyond the optic nerve, and lastly, we'll be discussing a little about visual reflexes. So, before coming to optic disc, I think most of you all know the visual, the path that the light rays follow before it hits the retina. Okay, so all the layers, all the structures it goes through. The retina is where we come in, so that's where we'll be starting. Okay, again, you're familiar with the layers of the retina, so I'm not going to go into the details. You know, the rods and the cones are the receptors, and they have various connecting interneurons and eventually the ganglion cells, whose axons pass out of the eye as the optic nerve. Once you are clear with these basics, now coming to what the optic disc exactly is. So the optic disc is basically what you see as the point where the axons of the ganglion cells exit the eye. Now, since this is like a punched out hole in the sclera and in the layers of the eye, so there's no retina at this point, okay, the point where these axons exit. Now, since the arrangement of fibers is centripetal, that's why you get this exiting point somewhere in the visual field. Okay, had it been a centrifugal arrangement, all fibers would have exited peripherally and there would have not been a blind spot, but that's not the case. Now, since there's no retina here, whatever light falls on this area, okay, is not going to be perceived. So we'll come to that later. I have basically divided this lecture into the clinical correlation would be in visual field charting, okay, or perimetry, and a direct fundoscopy. So what findings we'll get in each and how the optic disc looks in each of them. Once you're clear with this basics, okay, so a couple of things. The optic disc is also called the optic nerve head because that's the origin of the optic nerve. And there's no retina. We discussed this. So this forms the physiological blind spot. Okay, so it's a blind area, but it's normal. So coming to the visual fields, okay, we'll do this first. Now, visual fields, as you know, is it's charted by perimetry. Just to orient you, the right eye and the left eye, it's got a x-axis and a y-axis. Now, the center of the visual field is typically the center of fixation of vision. Now, this center is at the macula. We'll be coming to the macula in the next lecture. And from the center of the visual field, okay, or the center of fixation, where is the blind spot? So let's come to just one single visual field. Now, the blind spot in a visual field, okay, all measurements are in degrees. So it's the angle that subtends. So in degrees, the blind spot is 15 degrees temporal, okay, to the center of fixation. And it's typically 2 degrees above the horizontal axis, 5 degrees below the horizontal axis, and another 5 degrees in width. Okay, so that's how you perceive the blind spot. Why are these measurements important? Because there's something called an enlarged blind spot. We'll come to that in the next slide. Okay, so if this blind spot is enlarged, that's pathological. But these dimensions of the blind spot are physiological. and the location typically is temporal to the center of fixation and slightly inferior. Now, this is the enlarged blind spot. Logically, when would the blind spot be enlarged? Okay, so the blind spot corresponds to the area of the optic nerve head. Now, if the optic nerve head is enlarged, okay, most commonly due to papilledema or any disc edema, uh, this blind spot would enlarge. Okay, and that's where those dimensions that I told you come in. If it's larger than that, it's called an enlarged blind spot. Typically in neurosurgical practice, we'll be seeing this in papilledema. A little bit about direct ophthalmoscopy. Most of you know this. Okay, it's to be tested with the right hand of the patient's right eye using your right eye, and the same for the opposite side. Now, I wanted to mention a little about these. So these are the various apertures available, and these are the filters available. So when do you use a large aperture? When do you use a small aperture? And when do you use a red free light? So these are the main things that we'll be using. Now, those of you who know, who are into photography, what's an aperture? So aperture is that setting of the camera, or that function where that decides the amount of light that enters the camera and hits the sensors. Okay. In case of direct ophthalmoscopy, since your ophthalmoscope has a it emits a light, it's got a light within it. So this aperture is for the amount of light that exits the ophthalmoscope. And in direct ophthalmoscopy, again, the light that is emitted from the ophthalmoscope falls onto the fundus, is reflected from the fundus, and that's what you see. Okay, so what is the natural aperture of the eye? Let me ask you this. The natural aperture of the eye is the pupil. Okay, so if you have a large dilated pupil, you can use a large light. If you have a small undilated pupil, use the small light. What will happen if you use a large light on a small pupil? Okay, it's going to get reflected off the cornea. So if you have a large aperture in the iris, you use a larger light. Okay, again, medium is on the same principle. So it's usually a small or a medium for undilated pupils and a large for a dilated pupil. Red free light is to see blood vessels. Okay, you can remember that. For blood vessels and hemorrhages, you use a red free light. Don't worry about the blue light right now. So a little about the anatomy of the optic disc. Now, you know that the optic nerve originates in the orbit nasally and moves temporally. Okay, this is temporal, this is nasal, this is an axial section. So it moves temporally, okay, or it moves laterally, but at the point where it enters the eyeball, okay, it rotates slightly, and the insertion of this is at 90 degrees. So how is this relevant? When you do a direct fundoscopy and you observe from the front, the optic nerve head is going to be, you're going to be seeing it bang on, okay, you're going to be seeing it face on. You're not going to be seeing it at an angle. Although the nerve is at an angle, the head of the optic nerve inserts at 90 degrees. Okay, now this is normal. There are certain times where this does not happen, and this is called a tilted disc. So what is a tilted disc? When the optic nerve head also inserts at an angle, okay, acute angle to the tangential line of the posterior orbit of the posterior eyeball. Now when this happens, okay, this is how you see it in a cross section. So the nasal part is going to be elevated and the temporal part is going to be thin. Okay, as opposed to a even nasal and temporal when it inserts at 90 degrees. So this is seen as an elevated nasal part on fundoscopy, and of course if the nerve head is thinned out, what you're going to be seeing is the sclera posterior to it through a direct fundoscope. So this is seen as a temporal halo. It's seen in a case of a tilted disc. The measurements of the optic disc, again, as seen through a direct fundoscopy, vertically it's about 1.8 millimeters, and in width it's 1.5 millimeters. The color is typically pink to yellowish white. Why? We'll come to that. So as you know, all the nerve fiber, all the axons in the retinal nerve fiber layer are unmyelinated. Okay, and this is important for the light to go through them and hit the rods and cones. Now, they have to be myelinated at some point of time, of course, otherwise conduction would be too slow. So when these fibers exit, okay, when these fibers exit through the optic disc, okay, there is a plate called a lamina cribrosa. Cribrosa means, perforated, so it's got multiple holes, and when the axons pass through this, they emerge myelinated. Now, the important aspect about this myelination is, since the optic nerve is essentially an extension of the CNS, okay, it's even got the meningeal layers surrounding it. So because of this, this myelin is central myelin. Okay, so it's contributed to by oligodendroglia, not by Schwann cells as in peripheral nerves. One optic nerve typically has 1.2 million axons, okay, arranged in fascicles. So it's got about 400 to 600 fascicles, and 1.2 million axons per optic nerve. So this is what we discussed. They enter unmyelinated, they exit myelinated, and the optic nerve itself is surrounded by the meningeal layers. Why is this extremely important? Because the intracranial pressure of the head, okay, is transmitted to the optic nerve, transmitted to the optic nerve head, and that is what we perceive as papilledema. So the dura is typically proximally it's continuous with the periosteum of the optic canal. We'll be coming to this more in the lecture on optic nerve. And distally, it's continuous with the Dinon's capsule that covers the orbit. Okay, so the next big topic that's relevant for us as neurologists and neurosurgeons is papilledema. So this is the mechanism of papilledema. Okay, I've tried to simplify it a bit. Raised ICP um, causes increased pressure on the optic nerve, as we discussed. It's transmitted. Okay, causes, now whenever there's increased pressure on a nerve, what's going to happen? The routine exoplasmic flow that occurs from the periphery to the CNS is going to be hampered. Okay, now if that flow is hampered, the exoplasm is all going to collect in the optic nerve head, and that is what is perceived as optic disc edema, or what we call as papilledema. So what is papilledema per se? Papilledema is disc edema in raised ICP. So you'll have other causes of disc edema that we'll come to, but in raised ICP, it's called papilledema. Okay. Now, this axonal swelling of the optic nerve head, if it continues, all the venous structures, veins are very collapsible. These venous structures are eventually going to collapse, and that is going to cause back pressure changes. So there's initially going to be back pressure on the capillaries that are going to engorge. This is going to be seen as a hyperemic disc, okay, a red fiery disc. There's further going to be venous engorgement, and they are eventually going to burst and cause flame hemorrhages. So you also know that flame hemorrhages are basically bleeds in the nerve fiber layer. So because of the arrangement of nerve fibers, the hemorrhage occurs as a flame. Okay. We've already talked about this. Now, when it comes to fundoscopy, okay, measurements are in terms of the disc diameter. So if you want to see how far the macula is from the optic disc, you say, okay, so if the optic disc is, say, this wide, the macula is roughly twice that width away from the optic disc. So it's 2 disc diopters away from the optic disc. Okay, since the optic disc is nasally, the macula is going to be 2 disc diopters temporal to the optic disc. We spoke about the measurements already. Now, this is typically what the picture of the fundus that you will be seeing. So on direct fundoscopy, this is borrowed from American Academy of Ophthalmology. It's given the Frisians grading. Okay, it's called the Frisians grading of papilledema. So a grade 0 is, it looks more or less like a normal disc. There is no halo, no obscuration of the peripapillary nerve fibers. Grade 1 you have a C-shaped halo. Okay, so it's going to be an incomplete halo. Again, you know this is caused due to the swelling of the axons, but it's not going to be complete. So that's grade 1. Grade 2 is where there's a complete halo. Okay, it's circumferential. Grade 3, now you start looking at the vessels. So in grade 3, the vessels will start getting obscured because of the axonal swelling. So typically where the vessels leave the optic nerve head, okay, you can see the arrow here, also here. So these are points where you will see obscuration of the major vessels. So that's a grade 3. Grade 4 is where major vessels are obscured on the optic nerve head itself. So on the optic disc where the vessel emerges, you won't be seeing it clearly. Grade 5, at least all vessels are partially obscured on the optic nerve head. Now, this is a slightly more simplified version of the same. You can also divide it into an early papilledema, a fully developed papilledema, a chronic papilledema, and lastly an atrophic papilledema. But before that, I want to mention this. So most of you also know about, you might have heard this before, spontaneous venous pulsations. Why is this very, very, very important? If you see spontaneous venous pulsations, okay, I'll tell you how to see them. If you see them, it you can safely infer that the intracranial pressure is below 200 millimeters of water or 20 centimeters of water. So you know the mechanism already. If the axonal swelling is too much, okay, there's going to be venous outflow compromise. So if you can see that outflow, now how do you see it? You see it at the point where the vein leaves the optic nerve head. Okay, so where the vein emerges and bends, I'm so sorry. So where the vein emerges and bends, that's where you look for the pulsations. How do you see them? So a side-to-side pulsatory movement is very difficult to appreciate. Okay, fundoscopy itself is difficult to appreciate, and in that, a side-to-side movement in the vessels is difficult. So what do you look for? You look for the blood column within the vein, okay, and you will see that oscillatory nature of the blood column within the vein. That's what you call a spontaneous venous pulsation. So if you see that the ICP is less than 20 centimeters of water, that's the earliest sign. So loss of spontaneous venous pulsation is the earliest sign of papilledema. Now, why have I written loss of previously observed SVPs? Okay, because in 10 to 20% of the population, you are going to have normally absent SVPs. So nothing to do with raised ICP. 10 to 20% of people, normal people, you're not going to be able to visualize SVPs. So if you have a patient in whom you know SVPs are visible, and now the SVPs are not visible, that is very specific. Okay, and that tells you it's early, it's impending papilledema. Now, from there you come to early papilledema. Now again, you follow the same flow chart. Okay, so early papilledema is going to be where the disc hasn't enlarged. Okay, the disc has not come up, it's not elevated, but there is going to be some amount of hyperemia of the disc due to capillary engorgement. There are going to be signs of early of impending disc edema. So that's early. Fully developed papilledema is where the entire optic nerve head is elevated from the rest of the retina. So that you're going to see as, vessels might appear humped again because it's elevated. So a vessel will be humped and then will go down and go over the rest of the retina. You will have hyperemia, you will have obscuration of margins, okay, all the other features. Then you come to chronic. So chronic is where it's called a champagne cork appearance. Okay, so the disc is going to be elevated, but the hyperemia and all other vascular changes will be less. Okay, they'll be compensated for, but you're still going to have a swollen and an elevated disc. So that's chronic papilledema. And the last phase is when all this continues for a very long time. What's going to happen eventually is the axons are going to die out. Okay, the axons are going to atrophy, and that's known as the atrophic phase. So this is called secondary optic atrophy. That's the last final stage. So you have a chalky white disc. Okay, the axons are all gone. This is where the visual fields and the vision will per se start getting affected. So we haven't spoken about vision yet. So in papilledema, okay, typically vision is not affected. Now, there's some books give this, that if the doctor can see and the patient can see, okay, that means if you can see changes in the fundus and the patient can see, as in his vision is normal, okay, that is going to be papilledema. Doctor can't see, so if the fundus is normal and the patient can't see, okay, so the patient has visual problems, that is typically a retrobulbar pathology. So the pathology is not in the optic nerve head, the pathology is behind it. So the nerves are affected, okay, but your optic disc is going to be seen normal. We'll come to that later. So vision is not going to be affected in all these stages, okay, because the axons per se, although the axoplasmic flow is reduced, the axons are intact. Vision is going to be affected here when optic atrophy sets in. The second misconception I want to clear is, people think uh, papilledema is a very chronic process. Acutely elevated intracranial pressure will not cause papilledema. Now, that's not the case, okay? Papilledema, yes, usually takes days to weeks, but in acutely elevated ICP, so for example, aneurysmal rupture, subarachnoid hemorrhage, you are going to have papilledema. You can have papilledema within a few hours as well. Okay, so now papilledema is disc edema due to raised intracranial pressure. What are the other causes of disc edema? So most commonly and typically what you have is optic neuritis. You have AION, anterior ischemic of optic neuropathy. You have central retinal vein occlusion, and you have any kind of compressive pathology in the orbit. Why have I specified in the orbit? Because typically compressive pathologies or tumors in the optic canal and intracranial tumors will not cause disc edema. Okay, they usually would cause disc atrophy, optic atrophy. Uh, so what's pseudopapilledema? Now, pseudopapilledema, as the word suggests, looks like papilledema, but it's not papilledema. Okay, it's not associated with any kind of raised ICP features. When can you get it? Optic nerve drusen or myelinated nerve fibers are the two common conditions. Benign conditions, harmless conditions, but this is what it looks like. This is an optic nerve drusen. Okay, you can see the irregular, slightly blurred disc margins that you can mistake for papilledema, but is not. Secondly, this is what a myelinated nerve fiber looks like. We discussed axons in the nerve fiber layer are not myelinated, okay? But sometimes the myelination extends beyond the lamina cribrosa into the nerve fiber layer of the orbit, and this is what it'll look like. So you won't see the optic disc, or you won't see part of the optic disc, and it'll just be blurred like this. So you need to identify these conditions. You need to know they are not papilledema, and even if they even if you see them in cases where you suspect a raised ICP, okay, you need to know that this is different, and in these cases it's very difficult to comment on if the patient actually has papilledema if he has raised ICP features. Other conditions, this is called Bergmester's papilla, primitive hyaloid artery. Tilted disc, as we discussed, the nasal part of the disc will be elevated, and in extreme hypermetropia, you can get pseudopapilledema. Optic atrophy is so secondary optic atrophy is where we come in terms of papilledema. Okay, long-standing. There is already a pathology in the optic disc, which eventually leads to optic atrophy. Primary optic atrophy is where there are primary conditions, either toxic or metabolic or compressive, is what I told you just now, that in the optic canal or in intracranial pathologies compressing, you can have primary optic atrophy. So there you have a normal optic nerve head, and you directly have a optic atrophy. So a few more important points with respect to the optic disc that you need to know. Optic atrophy one type is that's important to neurosurgeons specifically is called a bow tie or a band optic atrophy. Okay, so this we'll be coming to when we discuss the macula, but this is basically a rough diagram of how the nerve fiber layer is arranged in the retina. Okay, this is nasal, this is temporal, that's your macula. This is the main bundle that goes from the macula to the optic disc called the papillomacular bundle, okay, PMB. And the rest of the fibers arch around like this and enter the optic disc. Now, something lovely about vision and about the visual pathway is that the orientation of the axons, okay, the orientation of these axons stays in a very orderly fashion. It doesn't get mixed up. It stays very orderly right till the occipital lobe. Okay, we'll be discussing that in the optic pathways. So anyway, this is going to carry the nasal macula fibers, okay, and these are the nasal retinal fibers. So what happens in band optic atrophy is this bundle is affected. Now it's going to be affected in typically in optic tract lesions, so we'll come to that later again. But if the nasal macular bundle is affected and the nasal uh, retinal fibers are affected, what you're going to have is just this part is going to atrophy and this part is going to atrophy. So you join them in the center, you get a band. Okay, so this is normal. This is your band optic atrophy. So it's typically seen in optic tract lesions. We'll come to that later. Another important point is Foster-Kennedy syndrome. This is asked a lot in exams. Foster-Kennedy syndrome, pseudo-Foster-Kennedy syndrome, pseudo-Foster-Kennedy syndrome, and there are some pseudo-Foster-Kennedy syndromes. Okay, so we won't get into that. Foster-Kennedy syndrome was initially described for a olfactory groove meningioma. Okay, it's anosmia with unilateral optic atrophy, and the optic atrophy is due to direct compression over the optic nerve, and contralateral papilledema, that's due to raised ICP. Okay, and anosmia is of course due to the olfactory groove tumor. That's Foster Kennedy. Okay, pseudo Foster Kennedy syndrome is where there is no olfactory groove tumor. Okay, but you still have unilateral optic atrophy with contralateral papilledema. Now, what conditions can cause this? Okay, you have a condition called the condition that we discussed for optic atrophy. Okay, either optic neuritis or anterior ischemic ophthalmic neuropathy. Now these conditions can initially affect one eye and after a long time can start affecting the other eye. So if you actually look into what these conditions are, we won't be going into the details of these, but all of them essentially cause disc edema initially, and as a long-standing process they cause optic atrophy. So if a anterior ischemic ophthalmic neuropathy or a optic neuritis initially affects one eye, okay, causes edema there, causes optic atrophy there, and after some time the initial process starts in the opposite eye. So you're going to have optic atrophy in this eye and optic disc edema in the other eye. So that's pseudo Foster Kennedy. Okay, it's not due to a tumor, it's due to a primary condition of the optic nerve head itself. Pseudo Foster Kennedy syndrome is basically where you do have a tumor. Okay, you do have an intracranial tumor. In this case, it's not an olfactory groove meningioma, but you do have an intracranial tumor that's causing compressive optic atrophy on one side, and you have one of these processes. Okay, either a anterior ischemic ophthalmic neuropathy or a optic neuritis, basically a primary process of the optic nerve head that is causing a disc edema on the opposite side. So this disc edema on the opposite side is not due to raised ICP. Had it been due to raised ICP and had it been olfactory groove meningioma, it would have been Foster Kennedy. So this is another intracranial tumor causing optic atrophy but not causing raised ICP, and disc edema on the other side being due to another process. So that's it for now.